All right, our third speaker is Dr. Alex Okun. He is the Associate Professor of Pediatrics at the Medical College of Wisconsin and a pediatrician in the Special Needs Program at the Children's Hospital of Wisconsin. His academic interests are in ethical issues surrounding palliative and end-of-life care, care for children with disabilities, and the training of interns and residents. He will be speaking about whether it's ever acceptable for healthcare providers to lie on behalf of their patients. Dr. Okun.
Thank you. Much happier to follow that introduction than your talk yesterday, which was amazing. In his 1965 book called The Importance of Lying, Ludwig wrote, quote, "The subject of lying has been so beclouded with moral issues that few have bothered to evaluate the benefits or services this behavior provides for man. Most people would not even consider the possibility that lying might represent one of man's most important faculties for coping with realities." In the talk I'm going to give, I'll review some conceptualizations of lying and remind us what the focus of attention has been to date in the discourse about physicians lying. I'll take us through three very unexceptional, mundane, everyday cases as opposed to the usual. Do a brief review of the literature from the last 2 millennia on the religious and philosophical discourse on lying. Go through some potential benefits and harms and review some professional obligations towards a process-oriented approach to our being able to decide what to do. I don't have any financial conflicts of interest, but I think it's important to acknowledge in discussions like these that we all bring personal biases to our presentations. Maybe it's not right to call this an altruistic bias in my clinical care. Maybe it's better to call it beneficent, like Lainey would have said yesterday. In terms of an anti-establishment leaning, I mean, I'm very uninhibited to challenge what bureaucracies and bumbling systems that restrict patients' liberties set out as rules. And I think that many of us, including me, have self-affirming biases in our talks, which is to say that we're here to justify what we actually do. I'm going to, like I said, review some the religious and philosophical discourse about lying from St. Augustine to Jeff Bluestein. And when we're talking about the professional obligations, hopefully they can guide us to decide what we can or can't do. Aristotle classified lying in through a few different mechanisms: fabrication, overstatement, understatement, or omission. And I think we'll find that all of these can describe the ways that we physicians sometimes lie on behalf of patients. They may not be a useful way for us to decide what to do. Aquinas characterized lies as officious or helpful, which is mostly what we're going to be talking about today, as jocose, meant to be humorous. A nurse, a philosopher, and a chaplain walk into a bar, and something like that. Augustine spread out this distinction of lying into 8-fold categories. The most permissible or least impermissible ones being lies which harm no one and yet save someone from physical defilement. In contrast to conscientious objection, which we were hearing a lot about before, Rawls described conscientious evasion, the difference being that conscientious evasion may be much more covert. It's not necessarily a public announcement of protest, and the teller of the lie is still doing this for conscientious reasons, but isn't necessarily meant to be discovered. And Bluestein took this formulation and put it into medical professional actions and called it physician noncompliance. Now, the cases that I'm going to go through soon, and I apologize because at this point in the conference we may be tired of more cases. It's like the first day on service, and like by the end you can't know which kid has what. But I think the cases will illustrate these points. Most of the attention in the discourse to date has been on crisis situations with patients who are in extremely dire conditions. And physicians lying has been discussed in the course of gaming the system, which is when health professionals break rules or regulations regarding access to care or payment in order to grant patients the treatment they need and do so for the sake of the patients. There are some references in the back part of the slides in this handout that go through that list some of the classic articles in this regard. Another type of lying, physician lying that has been in the literature is benevolent deception or therapeutic non-disclosure, which is where health professionals withhold or even fabricate information that they have reason to believe would be both critically important to the patient or their loved one, but which they are worried will harm them immediately. And so they deceive the patient out of a wish to protect them usually in the short term. Now, for the rest of this talk, I'm going to be focusing on cases that are not exceptional, they're not extreme, and they're not crisis. They're everyday. They come from my experience as a preceptor in continuity care, primary care clinic for residents in a standard residency program. These are cases which are not going to go viral or even fungal, but which give us a chance to sweat the little stuff. So consider that you're doing a health supervision visit for a 2.5-year-old who still needs recertification for WIC, the Women, Infants, and Children's Program. And on this recertification form, you write the height and weight, and they want a current hemoglobin. But the child's hemoglobin, which you were screening, was normal at 12 months and 24 months. And so it's not medically indicated to screen yet again for iron deficiency anemia. You're past the prevalent time. Question, should the provider make up a normal value for the hemoglobin and enter it on the form using a current date? Case 2. You're seeing a 7-year-old patient who you've known for a while with congenital HIV, and the family wants him to enroll in an after-school program, and there's a health form that goes along with the enrollment process. The family prefers still that his congenital infection not be disclosed. Should the health care provider list the child's HIV status on the form anyway, or keep it off the form? In the final case, and this may be for the half of you that are in intensive care, however many of you are in critical care, this might be something which comes across your work duties more than the other cases. The family of a child with a complex chronic health condition or technological dependency or just a lot of intensive care needs at home, seek help authorizing the approval of a visa for a relative to immigrate to come to the U.S., live with them, help take care of the child, and relieve some of the strains on an overwhelmed set of family caregivers. And you're drafting your letter, and you want to write about how overwhelmed the mother is and how there's nobody else to help her, but you actually know that she has a very, very helpful boyfriend who may or may not be here without immigrant documentation, and that there's a sister who lives nearby who sometimes helps, but you know that if you put that information in your letter, it would weaken the case, advocating for the visa for the relative who wishes to come here and help. So when you draft this letter, should you mention those sources of support or leave them out? I'm neither a theologian nor a philosopher like today's speakers and the ones before, so you'll forgive me if I say some of these things kind of superficially. I think for Kant, this whole discussion would be a walk in the park. In fact, he might walk out and walk to Safeco Park because he wouldn't engage in case-based discussions anyway. For him, lying in the ethical sense, as he wrote, is to be viewed as the transgression of a duty to oneself, since it injures the respect for one's own person. Lying is always wrong, no matter for what and why. If Kant had gone into general pediatrics, then I think after the part of the visit where he counsels families on the dangers of youth boxing or falls from windows or balconies or the dangers of riding in the back of a pickup truck, not to mention the additional risk of concussion from youth hockey and body checks and keeping guns out of the house or safely stored with their bullets, removed and locked up, he would counsel parents never to lie to their children about the Tooth Fairy or Santa Claus or the Easter Bunny. Augustine, a little more flexible, argued that the intent mattered and that the agent's inner attitude was important. Aquinas, hundreds of years later, wrote about discretion and that you don't have to disclose everything. Erasmus took this to a public domain and justified leaders lying to the masses. If he'd been in the presidential cabinet in the earlier part of this millennium, he would have, come up with the idea for the conference on the aircraft carrier with mission accomplished. Yeah. Paul, in this letter to the Corinthians, advocated for lying through the use of ambivalent or ambiguous language. He didn't advocate for lying, but he said it would be more permissible to do it that way. And finally, Spinoza wrote about lying being the lesser evil in some double binds. Now we can analyze what the provider should do in each of these instances from a consequentialist calculus, and how that the balance of benefits and harms for these parties involved, and then it's going to get more complicated. But just looking at it this way first, the patients, the children in these three cases, right? There's the case of the child with a WIC form. Should the provider lie and make up a hemoglobin and put today's date? There's the child with congenital HIV who needs a form to get into after school. Should the provider write the HIV diagnosis on the form, even though the family doesn't want it? And the third case is the child whose family wants to help a relative come here. Okay, I would say that in all these three cases, the children would benefit from a lie. The child in the WIC form wouldn't get a finger stick. The confidentiality of the 7-year-old with HIV would be protected. And if it's true that the relative coming here will help, the child with medical complexity at home will have an additional caregiver. The families likewise would be helped. I mean, in at least two of the cases, this is what the families are asking the professional to do. For others in the community, are they helped or harmed through the lies told in this case? Well, in the case of the WIC form, it's not like the doctor is fabricating information that will otherwise entitle a child to get WIC benefits who might not be entitled with the truth put in. He's not making up that the child only weighs 13 pounds at 2.5 years or that he has a profound anemia. The interests of the other children in the after-school program really aren't that affected by the presence of a child there with congenital HIV. We might have thought so back in the day when, like Mark was talking about, when some doctors didn't care for people with HIV. Now, as far as service delivery systems, the WIC office, the school, the after-school situation, the immigration office, I think those systems rely on that the information, or assume that the information they receive is truthful. So they're not helped by these fabrications, omissions, or lies. I think you could argue that the after-school program will be better off by a timed disclosure, if there is going to be disclosure about the child's status, with a chance to educate staff who might, as many of us have seen happen, otherwise have a very brisk and unthought out or uninformed reaction to the first instance they ever knew about an HIV positive child in their program. Well, that's enough about everybody else. What about us? Like we said yesterday, lying on behalf of our patients in these instances certainly has some benefits. It promotes what Mark was referring to, the internal morality of medicine, to benefit others, take care of patients' health. It helps us realize our beneficent obligations, and for some of us, we derive satisfaction from defeating unjust systems. But there are harms involved. If our lies are discovered, there may be repercussions. These lies may erode the trust that patients have in the medical system. Well, if my child's doctor is going to lie about this, how do I know he's not going to, lie about some coding issue? Parents are very concerned about coding. It could create religious and existential crises for providers. And finally, for those of us who work as mentors or faculty or role models, we don't want the people that we're supervising to see us lying and not be able to discern when that's a good thing or a bad thing. The next thing you know, they may be signing sick notes in Madison in February. We have professional obligations as well. I think the strongest obligations arise in the case of the 7-year-old with HIV to defend the confidentiality and the privacy of the child and often his mother. And with more time, we could go into that. But we also have obligations to contractual justice. If we have any particular agreements with these agencies that we're writing these forms for, we have an obligation, like Lainey talked about, to do our parts to maintain distributive justice. And I alluded a little bit before to how distributive justice might be threatened by, or might not, by some of these lies. We are moral agents, as Mark said, and for some of us, even these lies will threaten our moral integrity. So, what would you do? I think that the case for leaving the HIV status of the child off the after-school form is the strongest here, because the disclosure is an issue which happens over time. Everybody can benefit by this disclosure being decided carefully, with a lot of support and with a lot of education. The WIC form lying and putting a normal hemoglobin on and dating it today, I think may be hard to justify. I think you could argue that all 2.5-year-olds just need to reconcile themselves to every time they come to see you, they're going to get poked. And, it's too bad, suck it up, you're a kid. But on the other hand, if you were taking care of a 2-year-old or 2.5-year-old who was particularly fearful and completely panicked about needles, you could argue that the goods that would come from avoiding his having to be stuck for no good medical reason outweighed the negatives of lying. And in the advocacy letter for the relative, I would say that, and you might have a different take on this depending on your own moral approaches to omission or commission, it would be okay to omit the mention of those relatives. Because after all, if you mention in the letter that although this mother has tons of support from the community, I'm asking you, immigration, to approve the visa for yet another form of support, who are you really helping, and why are you even writing it like that? But if the immigration office were to come back to you and say, Dr. Okun, could you please clarify this? Are you sure the mother doesn't have any help? Then you have a hard time lying about it. Well, these are the small situations that become very interesting to analyze, and sometimes are a nice relief from the big major viral cases. I thank you for the chance to discuss these real-life situations.
Any questions? Well, I have one that's somewhat tangential, but and maybe just a comment, but I really liked the 3 cases that you chose. I thought what it exemplified for me was just the concept of everyday ethics with our trainees. There's a lot that we talk about in ethics that's, regarding tragic situations, and a lot of our trainees think about ethics only in those terms, but it's these cases that they see every day and are incredibly prevalent that they almost don't see because of that. And maybe you can speak to how you increase their ethical sensitivity to addressing those situations that they come across every day in their practices.
I think looking at the everyday situations and the ethical considerations of the everyday situations and the everyday things we do has a number of appeals. For one thing, in a resident or medical student education curriculum like Dr. Kesselheim works on and others, it's the everyday cases which can feel more pertinent to early learners and actually have been experienced and therefore are very, it captures their interest. They also can be a starting point to understand how you deliberate ethically in a way that can pull more people into the field. And they're certainly more prevalent, so if you want to look at a public health model of ethics, they are pertinent to a larger proportion of the population.
Okay, thank you very much, Dr.
Thank you.
Okun.